Good afternoon. I'm Kate Ellis, Director of Research Programs at the National Institute for Healthcare Management Foundation. On behalf of NIHCM, thank you for joining us today for this important discussion on food insecurity in the United States. The most recent data from the United States Department of Agriculture found that 34 million individuals in the United States were living in food insecure households in 2021, equating to just over 10% of households. So while most households had consistent access to food, there was a sizable amount of households that experienced food insecurity at times during the year, meaning their ability to acquire adequate food was limited by a lack of resources, rising costs, or other access challenges. Today, we'll hear from a prestigious panel of experts to learn more about the impact that food insecurity is having on families and communities, the connection between food insecurity and health, and strategies to improve access to affordable and nutritious food. Before we hear from them, I want to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped to convene today's event. You can find biographical information for our speakers, along with today's agenda and copies of slides on our website. We also invite you to join the conversation on Twitter using the hashtag #FoodInsecurity. I am now pleased to introduce our first speaker, Dr. Hilary Seligman. Dr. Seligman serves as a professor of medicine and of epidemiology and biostatistics at the University of California, San Francisco. She directs the Food Policy, Health, and Hunger Research Program at UCSF Center for Vulnerable Populations and the CDC's Nutrition and Obesity Policy, Research, and Evaluation Network. In her work, she conducts research and policy evaluation focused on food security interventions in healthcare settings, federal nutrition programs, and income-related drivers of food choice. We are so honored to have her with us today to help us understand more about the relationship between food insecurity and health.
Well, thank you very much for inviting me to talk about this topic today. I'm going to frame the conversation around food insecurity and health and try to tee up some specific strategies to address community needs. Next slide. As Kate just mentioned to you, in 2021, about 1 in 10 households in the U.S. Were food insecure, and this includes about 6.4% of U.S. households that the USDA terms households with low food security. These are households in which the quality of food had to be decreased in order to meet a severely constrained food budget. And another 3.8% of U.S. households who live in what the USDA terms a household with very low food security. And in these households that have even lower food budgets, it's both the quality and the quantity of food that have to be decreased in order to meet food budgets. Next slide. There are substantial differences in food insecurity by race. These are the most recent numbers that have been released by the USDA, which shows you much higher rates of food insecurity in Black, non-Hispanic, and Hispanic populations. These are the official numbers released by the USDA using their terminology. I think it's important to understand who is missing in this graph, because there are also significant disparities between food insecurity rates in white populations and food insecurity rates in Native American indigenous populations, as well as some Asian subpopulations as well. And it's very important that we keep these populations in mind as well. Next slide. So increasingly, when we talk about food insecurity, we're talking about food and nutrition security together. Food security is defined by the USDA as access by all peoples at all times to enough food for an active, healthy life. The term healthy in that definition is important and is a part of the construct of food security. But the concept of nutrition security has really come into focus lately as a way to put increased emphasis on the importance of elevating not just food security, but diet quality and equity when we're talking about food insecurity in the United States. And so I want to understand the term nutrition security and use that term perhaps in today's discussion to really focus on diet quality, because diet quality is really a primary outcome that we're interested in when we're talking about food insecurity in the healthcare setting. And it also elevates the importance of equity in all of this work. Although this isn't quite correct, I think an easy way to shorthand this or the way that this has been understood by many as a shorthand would be that food security is having enough calories or sufficient number of calories, and nutrition security really focusing us on making sure that those calories are the right kind to address the increased risk for diet-related chronic diseases in everybody in the United States, but particularly in populations that are at the highest risk for food insecurity. Next slide. So when we're talking about diet-related chronic diseases in the U.S., we have to hold high rates of food insecurity next to a number of other important risk factors that are impacting the dietary intake of low-income populations in the U.S. These together construct what we like to term the dietary divide, and it includes high rates of food insecurity, increased difficulty accessing nutritious food in low income and particularly in Black neighborhoods because of lack of geographic access to full service grocery stores, unhealthy dietary intake, which is partially related to healthy foods being perceived as luxury items because of their increased cost. And we know that these factors together increase the risk of chronic disease, and that poor diet is the #1 cause of death in the United States because it serves as a potent risk factor for diet-related chronic disease such as obesity, diabetes, heart failure, and other heart diseases. And this increases healthcare costs. And this has been a primary motivation for the healthcare sector to have increased interest in addressing food insecurity in their own setting. Next slide. Next slide. So one of the ways that we have tried to quantify the burden of food insecurity on the healthcare setting is to look at the additional amount of money spent on healthcare expenditures per adult person living in a food insecure household when you compare them to a similar adult with similar comorbidities living in a household that is food secure. And if you multiply that increased expenditure value on healthcare, which is about $1,800 per year by the number of food insecure people in the U.S., what you find is that we spend about $77.5 billion annually on our healthcare expenditures that we think are roughly attributable to food insecurity. And this is one of the primary motivations, again, for the healthcare sector getting involved. Next slide. Now, one of the questions that people ask us is, well, could we save those $77.5 billion by better investing in food security interventions? And one of the things the answer to that question requires understanding is whether food insecurity is causing increased healthcare expenditures, or whether increased healthcare expenditures by decreasing capacity to hold down a steady job, increasing out-of-pocket healthcare expenditures, and other out-of-pocket expenses, whether being ill in the United States is just predisposing people to food insecurity. And I will say that this has been quite well studied now, and the answer to this question is that both are true. But the primary arrow, the most potent direction of this relationship is food insecurity causing poor health, and poor health driving an increase in healthcare expenditures, and not that an increase in out-of-pocket healthcare expenditures increases risk for a household to become food insecure, although this does happen too. And what this means from an intervention perspective is that if we can address food insecurity with food security interventions, for example, in the clinical setting, we may be able to decrease adverse healthcare events and decrease healthcare expenditures. Now, the poor health outcomes that have been associated with food insecurity are many, and I include some of those in the right-hand side of the slide. But the reason we can find associations between food insecurity and almost any health condition is because, in some cases, increased health expenditures increase the rates of food insecurity. And that has really driven us to think of food security interventions in the healthcare setting to really be focused on diseases that are highly sensitive to diet and particularly the quality of diet. Next slide. I was asked to address the overlap between food insecurity, healthcare outcomes, and COVID-19. And I think that the pandemic has really highlighted for us the really important ways in which the diseases that are associated with food insecurity are increasing morbidity and mortality in the United States and putting an excess burden in particular on low-income populations. all of the diseases that food insecurity predisposes people to because of poor diet quality and other risk factors are highly related to severe outcomes from COVID-19 as well. And so it is true that COVID-19 morbidity and mortality was much greater for people living in food insecure households. And again, a place where food security interventions would likely have caused improved health outcomes. Next slide. What this has meant, and in a broader context, is that it has forced us to again ask the question, do we need some realignment between healthcare and social care in the United States? I'm sure that this graph is familiar to many of you in this room, and it looks like when they changed the slide, the arrow moves. So the green circle should be around the US, not the UK. So move in your head that green circle over 2 bars to the US, where you can see that the US spends an outsized proportion of their healthcare spending on treatment of disease rather than prevention of disease through social care. And you see that in the 16% of our health and social care, 16% of our GDP that is spent on healthcare, as opposed to only 9% that's spent on social care. This is a drastic misalignment in compared to other countries, and makes us wonder the extent to which we need to increase our spending on social care in an effort to decrease spending on healthcare. And that has been a primary motivator between what we call behind what we call moving upstream. Next slide. And I want to be clear that moving upstream is a term used to talk about our capacity to improve community conditions or the root causes of disparities in the United States and disparities in exposure to social determinants of health. This is at the top part of this slide here, and we're really talking about laws, policies, and regulations that create community conditions supporting the health of all people. Where the healthcare sector has been engaged is really in this middle area, this midstream area of addressing individual social needs. Perhaps as a healthcare sector, we don't have the tools or the capacity right now to address these underlying systems and structures. But what we might be able to do is screen people, for example, in the clinical setting for food insecurity, and make sure that patients who are experiencing food insecurity have access to the resources that they need to become more food secure. Next slide. And because of this desire to move to this midstream area and to move some of our interventions addressing food insecurity into the clinical setting, there have been a lot of studies that try to model out what this would mean in terms of healthcare costs. And I show you one example here of a modeling study that is used to try to understand the impact of healthy food prescriptions distributed through the Medicare or Medicaid program, which in this case was defined as insurance covering about 30% of the cost of healthy foods, fruits, vegetables, whole grains, seafoods, plant oils, etc. And in this study, this incentivization or subsidies on healthy foods would become cost effective after 5 years, primarily by reducing the incidence of diabetes and cardiovascular disease. And this was modeled out to be more cost effective than many currently covered medical treatments, again reinforcing the potential importance of this in the healthcare setting. I will say this is not a single study that's been done that shows this. I'm elevating this one study, but there have been numerous other modeling studies that show very similar impacts. Next slide. That is it for me, and I'm looking forward to your hearing about some specific interventions in this space. Thank you.
Great. Thank you so much, Dr. Seligman, for sharing the relationship between food insecurity and health and really driving home the importance of nutrition security as well. Next, we will hear from Matt Habash, the Executive Director of the Mid-Ohio Collective, a leader in the Feeding America network that is made up of 5 Mid-Ohio assets working together to address the social determinants of health that place and often keep people in poverty. Matt takes an active leadership role in the community, having served on numerous boards, and has received various awards recognizing his commitment to and work in serving those most vulnerable. We are grateful he is with us today to share his efforts to increase access to nutritious food through partnerships. Matt?
Thanks, Kate. Good afternoon, everybody. And I've had the privilege of being in this role now this is my 39th year. So I've seen the evolution of food banking from the very beginning, in terms of, when we were first starting out to what it's really stepping in today, which is really trying to describe what the upstream conversations that Hilary, Dr. Seligman just mentioned. I've had the privilege of working her on a research project on diabetes in the local food bank Columbus area back in 2010 to 12. So it really is a shift in a lot of the work. I think it's important to recognize that each food bank across the country is different based on what they do, but collectively, we're really trying to advance. You can go to the next slide. Just to give you a sense, we shifted at the beginning, terrible timing, but we did it at the beginning of the pandemic, and it really was around the idea of shifting from just being called the Mid-Ohio Food Bank to the Mid-Ohio Food Collective, and it really was around recognizing the assets, but more importantly, around stepping into looking at our work differently. Rather than just being an emergency food provider, we had a lot of other things going on. We really had created a vision for many years. It was a hunger-free and healthier community, and we really wanted to step into that work. So the collective is really around these 5 circles. But probably at the foundation of that is the idea of right time, right place, right services. And it really is, how can we connect to our customers better? We shifted from client to customer language, but it really was first with the food bank, which is what we always do, but we're into a very much data-driven, smart response to how we do our work. We built a data tracking system, and I'll talk a little bit more about that in a second, but it really was around how to do that work that we're doing to make sure we could get the food where it needed to be. And it was also the right kind of food and at the right time for our customers to be able to access it. The strategy now around that is the markets. We're building these Mid-Ohio markets, which are 40-hour-a-week, multi-purpose facilities, so that we can look at the whole person to really start to address some of those upstream areas that that Dr. Seligman mentioned. But it was really around making sure that we were open and available when our customers needed us to be, not when it was convenient for the particular agency to be in the space. We have a farm, which I'll talk a little bit about. It's a high-tech urban ag farm that we're building out. Our Mid-Ohio kitchen model is really, we do the typical things that food banks do with after-school meals and summer feeding and those things, but it's also now stepping into, can we cook some of this amazing food that we're getting and have it ready for customers? So think about it from a convenience perspective. And finally, the Mid-Ohio Pharmacy. This has been our connection from the beginning. When we first started to do the diabetes research back in 2010 to 12, and also we got asked at Columbus to lead the national effort to, in fact, find the next 1 billion pounds of fresh produce and get it to food banks. Next slide. So as you step in, this gives you a little sense. This is some of us, as I said, we're data driven. This is our 20 county area out of the 88 counties in Ohio. The next slide next to it is a heat map of where the people come from to get services from us. You can see the major dark spot is the Franklin County, Columbus, Central Ohio area, 14th largest city in the country. Yet we have, a lot of other folks that are, 9 Appalachian counties, small county, rural areas that we also are trying to address. We can tell you this year that things are up considerably. We have 32% increase from 21 in terms of the number of Fresh Track is the data tracking system. That's the number of visits that people are already up this year, almost 45% in the last couple months. We're seeing an overall increase of 20% for the whole year. That's over and above, the pandemic numbers. So it's the scary part of this. And we have and this is probably the most amazing stat in it, 155,000 new customers, new families that have come to get help for the very first time in their lives. Next slide. You'll see from this the data is continuing to climb. This is, the numbers of people that we're serving, are at record volume. This is the highest I've ever seen it. It's higher than the peak of COVID. When you think about the fact that all the benefits from COVID ended, and pretty much with the exception of the enhanced food stamp still going on in Ohio, to the fact that we've had, inflation and record price increases across the board, whether it's food, housing, gasoline, whatever. I saw today gasoline went up another 45 cents a gallon based on yesterday's announcements. Next slide. This gives you a little sense, we're in the cooking meals and what we're doing currently. It's really around how many meals can we produce. This is for a variety of things, whether it's kid meals, community meals. We're doing a lot of soup kitchen meals now that are cooking that we didn't do before. This is all since the beginning of COVID that we've really stepped into this space about, can we have ready to eat food available and where it's needed? Stepping up when the shelters had to deconcentrate all the shelters during COVID, and we're continuing to feed all of the extra sites that opened up. A lot of non-emergency meals. We've taken over cooking for some schools, but it really is around, can we take fresh food and get it to people in a state that's easy to consume? Next slide. So this is the Mid-Ohio Pharmacy. This for us is really stepping into today's conversation for us. It really is looking at that midpoint, the social determinants of health, and where we can play a role. And I have to tell you, we're trying to reposition ourselves, as are some other food banks, as a low-cost, high-value healthcare strategy. If you think about all of what Dr. Seligman just said, this fits right into that, in the sense that we have surplus produce in this country, and if we can get it to people, and then because we have a data tracking system, we have the ability to match data with our healthcare partners, in this case, federally qualified health centers, that we're matching data. We're tracking over 30,000 patients right now in terms of seeing the health outcome. And if you use the modeling study out of Harrisburg, Pennsylvania, it's suggesting that a 1-point drop in your A1Cs is an $8,000 cost savings to Medicaid. If you give food banks a little bit of that money to continue to do this, then we can do it, all the time. The interesting thing here, the most amazing stat in our data system is that 36% of the people come once a year. 70% of the people come 5 times or less. So this idea that people get free food and come all the time is simply not true. The reality, if we get you coming 11 to 24, really closer to the twice a month, we're seeing the healthcare improvements, and we're not controlling for any other variables. We're just making readily good food available to people that are trying to manage their disease. In this particular case, it's diabetes, but we're really trying to address this and recognize, where can we step into this space? We just started a pilot with Weight Watchers, where basically we've got an early pilot with 75 families that were in the pharmacy program, really stepping into, to wanting to partner with Weight Watchers and to really have a free program to allow them to avail themselves of all of the work that's in Weight Watchers to help them manage, their weight in this process using the fresh food. The pharmacy program is simply designed where the doctor writes a script. We learned a lot out of that diabetes study. One of the things we learned was doctors don't even screen for food insecurity. So the idea that, when you talk to them, they didn't know what to do with it if they did. So we were connecting them, and we, really have been able to connect the doctors, write a script into the data system. When the particular patient goes and completes, the produce pickup in this case, we're able to feed that visit data back to the healthcare provider, and then eventually they feed us back data on health outcomes in an aggregate way. So that's where we're seeing the real benefits of taking surplus fresh food and getting it to people just as they need it, so that they in fact can have better health outcomes. Next slide. One of the things we're also doing in that space is really connecting. We've got Ohio State here, so we're doing additional research with them, really trying to take a look at some of these to make sure they work. This Mid-Ohio market, that's a picture of our newest market. You can only see a side of it. That's an actual 12,000 square foot convenience store that was only open for 18 months, brand new. We bought it in a high need area, and we began to let people come. It's already the second busiest distribution in our system. It's open 41 hours a week, overnights, weekend, as well as during the day. People come in, they get to shop it. They're allowed to come back as often as they need to come back. We're really trying to step into that space of having convenient hubs that are open when people need them to be, regular access to the fresh food, so they don't have to take a lot of it all at once. They can come get it, they can use it, they can get recipes, and we're even starting to look at how we use technology differently. So for us, this is really a step into what you're looking at is we just installed lockers. Those are refrigerated lockers where we can take the pharmacy script and put it in that locker. The person can pick it up. You got about 24 hours or so to pick up the product. They can come when it's convenient for them. We're going to test this, and at that site, we'll eventually see if this works. We'll put it in some of our rural locations and ask one of our partners in that area to continue to have ready food available, eventually with an order ahead. online ordering system that we've worked on nationally at Feeding America. Curbside pickup is what's currently going on because of COVID. Home delivery, trying to meet the customer where they are. Allowing them to get the program and treat it like it's a grocery store. This looks like a grocery store, and we're currently in the process of opening a number of other of these. We're stepping into a lot of the other work. The one-stop shop for us is really looking at kitchen prepared meals, partner clinics. We have a lot of organizations that are partnering with us in this space to take a whole look at what the particular people need in that area. The first 2 customers came through, got $7,000 and $9,000 in benefits they didn't know they were eligible for, whether it was for housing and for utility assistance. We're also able to, for people that want to enroll in the pharmacy program, to get them connected as well to healthcare. Next slide. The kitchen for us really is an evolution from what we're doing for us. And if I had to boil all this down, we're trying to make convenience a healthy choice. We run a restaurant where we cook healthy food. We feed the kids in a daycare, out of that restaurant, and the Boys and Girls Club, all around fresh, healthy food. But another part of it is, can we take the food that we have that's in bulk, that's produce, as I like to say, none of us go home every night and cook a meal from scratch. So if we give people a bunch of fresh food and they're a single parent, it's really hard. So can we take some of that food and cook it and have it ready to eat meals the same way we shop the perimeter of a grocery store? Can we put that in the markets? People can pick it up and in fact take it home, heat it up, and have a ready to good healthy meal. So we're trying to make the healthy choice a convenient one. We partnered, one of our first markets was on Columbus State's campus, which is a 35 to 45,000 student downtown Columbus 2-year college, and letting those students who are working, going to school, and trying to take care of their families have ready access to food. We just bought a food truck that we're really going to do it, take it to the streets, take it to festivals, putting healthy food in front of people, showing people how easy it is to do this. But that kitchen will be a lot of grab and go meals, and we anticipate, in 23, as to start the first year, we'll do over 50,000 servings. Next slide. Mid-Ohio Farms, we started with one small 3-acre farm. As I like to say, I'm not going to farm my way out of the hunger problem. The first year we did that, we grew 40,000 pounds of produce. We gave away 30 million pounds of produce several years ago. So we're prefer to have the farm from around the country that gives us the excess surplus, but we're using it as an education farm. What you're looking at on the left is how we leverage technologies. Those are growing towers using very little water. I think it's 5 minutes a day, twice a day, screened, growing a lot of leafy vegetables. You can grow a lot of things, even in the 5-gallon tub down at the bottom. You can grow some root vegetables in one of these towers. We'll eventually, as we expand this, we have 2 farms that we're setting up that will be able to literally teach others how to do this, use it as an edge of farm for kids, and really as an opportunity for where food comes. We've got high tunnels, we will have greenhouses, we will have hydroponics on this, and it's all designed to use it as a farm incubator program to really train local farmers on how to increase yields in urban areas, a different way of doing urban farming with minimal water kinds of things. Don't even need dirt. You can do this on asphalt, and a lot of K-12 education and community food and nutrition education out of that farm. So that's the last of our assets. You can go to the next slide, but really for all of this, if I had to boil all of this down, it really is, and this is something that I'm much bigger fan of using the language food is health rather than food is medicine. I know that's a fairly common term. And my only simple reason is somebody that's not a healthcare provider, and at least in the traditional sense, is that at the end of the day, I'm really trying to impact people's health. That's what for us is the new measurement is. And sometimes when I say food is medicine, it sounds too much like a drug. As our system, I happen to chair a hospital board for a number of years, and we have a sick care model. How do we transform it to a healthcare model? We believe we can take healthy, nutritious food that is available in this country and get it to people in a right place, right time, right service, right food model, in a way that we can impact their health. And we have an ability with the data to measure that. And we believe we can why not take surplus fresh food and get it to where it needs to be and have an impact on people's health. So for us, my new measurement of success is simply to look at this, not as the amount of meals we produce, the pounds that people serve, that what I call the widget counting. It really is to say, can I have an impact on our customers' health? And that's where we're trying to drive our entire strategic direction. Thank you.
Great. Thank you, Matt, for highlighting the value of community partnerships and giving us insights into the latest efforts in Ohio to improve food access.
Oh, I do
Next,
have one more thing you asked me to address,
oh,
and I got about a minute. It was that
yeah, go ahead.
the Dollar General. I forgot that. I'm sorry. Dollar General is doing what a lot of retailers are doing, and that simply is trying to take their excess product at the store level and get it to people. The beauty of Dollar General is they roll this out across the United States. Is the fact that they're in a lot of rural areas, so they hopefully it will provide some additional food. The same way a lot of other retailers across the United States don't want to waste their food at the store level. We're connecting direct agencies so they can pick up that food and make it readily available to well. So you'll see more about Dollar General following a lot of the other retailers across the country and making sure that food does not get wasted. Thank you. Sorry about that.
No, appreciate it. Thank you. Next, we will hear from Lance Chrisman, the Executive Director of Elevance Health Foundation. In this role, Lance leads the foundation's mission to advance health equity by improving health through strategic partnerships with community-based programs that focus on maternal and child health, food as medicine, and substance use disorder. We are so grateful to have Lance with us today to share Elevance's efforts to ensure equitable food access. Lance?
Thanks, Kate. Really appreciate the opportunity to talk a little bit more on the subject, and it's really exciting to be a part of this forum. I think Dr. Seligman did a great job in setting the topic up, defining the size and scope of the issue, and then Matt came in and with his Mid-Ohio Food Collective kind of gave you an idea of some of the systems and things that are in place. And so my goal, when you looked at the agenda, ensuring equitable food access is a pretty big piece of the pie. So what I'd really like to do is just give you an idea from a corporate perspective and more specific to my role, a private foundation or philanthropic perspective on how we are attempting to address the topic and get to some of those. I'll start with the macro and then drill down to some of the programmatic elements. So if you wouldn't mind advancing to the next slide, please. So at Elevance Health, our community health strategy really aims to address those health-related social needs, or some folks call them social determinants of health, through really using as much science as possible, evaluating data, and from that data, building evidence-based interventions so that we really want to be a part of the solution for health equity. I think that's the most important thing here. So that's at the broad macro Elevance Health perspective. If you go to the next slide, you'll see that we really view this, and this is really for my own, how I keep the buckets straight. We look at two different pathways to achieve this. If you look on the right, you're going to have our business perspective. You're going to have those folks that are driving to improve the health elements of our associates, our members, and our community as a whole, also on the right-hand side. But where I'd really like to stay for this presentation is on the left-hand side here with our philanthropic efforts through our foundation. This is for the broader community needs. It's for the greater good of the community, and really driving home some specific whole health measures, not only for individuals, but for our communities as a whole. So if you can go to the next slide and get into some of the details. Back in January of 21, we sat down with our strategy team at Elevance Health, and we did a full audit of our foundation approach from everything from our analysis, our social mapping, our evaluation of grant activity, to the dollars that were going out the door and what they were going to. And really, it was a 6-month review. Believe it or not, it was a very stringent review of everything that we were doing in the foundation footprint. And the findings came back and they said, you know what, you're doing a good job, doing a very good job, but you're trying to do too much for too many. You're spreading yourself very thin. And so the goal or the feedback from this refresh was you need to run deeper and focus on some specific health outcomes in specific areas, and really run deep in those areas. And so from that, we adopted a 3-year goal to spend up to $90 million in 3 primary health focus areas, with an additional focus. Obviously, at the time we were still, and we still are, in the pandemic, so we wanted to make sure we still maintained a focus in disaster as well. But for the purpose of this presentation, we adopted a 3-year goal of spending up to $90 million on 3 primary focus areas: maternal practices, reducing substance use disorder, and then the topic that we're really going to drill down on today, encouraging food as medicine. And I'm happy to say that that goal of 90 million, we are going to exceed that easily. We're going to blow right through it, and it's probably going to be between 100 and 150 million dollars by the time we actually get there. If you can advance to the next slide, I'll show you why. Drilling down into the food as medicine, although I do like Matt's comment on food as health, but we are a healthcare company, so we do stick with the food as medicine. If you could advance to the next slide, please. There you go. So specific to food as medicine, over the next 3 years, we're going to spend at least $30 million on the topic. And we've gone to an RFP process, meaning we define the specific geographies that we want to address food as medicine. We also define the specific health outcomes that we would like to see for the specific demographics. Then we submit an RFP into the community and have our nonprofit partners respond back if they have a program that fits. If you can go to the next slide, you can see over the past 1.5 years, we've already secured about $23 million and committed $23 million in grant activities. So halfway through, we've already got about 80% of the resources committed. You'll see those are, as I mentioned, we have specific health outcomes related to reducing food insecurity. We want to make sure we're addressing those specific health outcomes, such as reducing BMI, reducing hypertension. There are specific measures with each grant that we're looking at. And so you'll see some of the categories there that we utilize to get there. Next slide, please. This is what I really want to dig in on. Just to give you an example of a couple grants in the area, and at the beginning of this the forum, they were kind enough to say they had assembled a panel of experts, and I would absolutely say Matt and Dr. Seligman are absolutely experts, and I know just enough to be dangerous, but I do know to surround myself with experts. So specifically to kind of give you the 6 degrees of separation, Dr. Seligman was instrumental in helping us shape this grant to Feeding America. This is absolutely the largest grant in the history of our foundation. It's a $14 million grant over 3 years. And to continue with that 6 degrees of separation, Matt, one of our major entities that is implementing the program is the Mid-Ohio Food Bank, which is part of Matt's collective. So small world, but once again, we like to surround ourselves with experts. And this is a great forum. This is our 3rd iteration of the Food as Medicine program. The first iteration really spent the time on screening the patients, creating the intervention. And so with Food as Medicine 3.0, we're really spending more time in drilling down on collecting the data and tracking the data and conducting the evaluation. Feeding America has brought on a 3rd-party evaluator to help us look at the data, dig deep. Once again, you heard me say at the onset, use as much science to the art of this grant giving and impact that we're attempting to create. So we're really excited about this grant, just got it off the ground earlier this year. So we really look forward to watching the impact over the next 3 years with respect to this. So that's at the national level. To give you an idea of a local grant, if you wouldn't mind going to the next slide. A great organization here, actually in Indianapolis, is the Local Initiative Support Corporation, or LISC. We sat down with them and created a $2.45 million grant over the next 3 years to help address equitable food access in needy Indianapolis neighborhoods. We're really utilizing and sitting down and bringing together residents, community leaders, experts on the topic, and civic organizations to analyze the local issues, look at the local resources that are available, and develop achievable strategies to help address the cause. And I just noticed, I volunteered at a community garden on Saturday, and it was actually this community garden that's featured there. I didn't realize that was a photo of it. That's called Elephant's Garden, and it's in a food desert here in Indianapolis. And they have basically 2 residential lots that they have, a community garden on that is generating food and distributing it within that community into the food deserts there and beyond. So great model that is really getting at the grassroots level and leveraging the resources that are available in the local community. So we're pretty proud of that local grant. So just 2 examples of some grant activities that we are engaged in. As I mentioned, we have $23 million in commitments, so there are many, many more across the country, but these were 2 that I thought really highlighted some of the programmatic efforts that we're attempting to put in the community to make a difference. Next slide, please. But it's not all just about the money. We want to be a good community partner. So we've made those philanthropic commitments, but we also want to engage our associate base in volunteerism. Our associates volunteer year-round, but just before the holidays, in the September and October timeframe, we spill into November a little bit, we generate or create a program called Elevance Health Volunteer Days, where we actually structure over 100 planned projects in 30+ markets across the country, and then we target food insecurity with all of these volunteer opportunities. That's what I was doing on Saturday, as a matter of fact, was part of the Elevance Health Volunteer Days. And so we engage our associates, get out there, they roll up their sleeves, get their hands dirty in, food banks, collecting and sorting and packing food and distributing those, community gardens, so on and so forth. We really use the volunteer days as a springboard into the holidays. And so just through the volunteer days, this year we saw over 15,000 volunteer hours from over 1,500 volunteers. Now those are our associates, but we also use this, we invite their families, they can invite their neighbors, friends. We really use it as a community building opportunity and a culture building opportunity at the same time. And this just adds to, as I mentioned, we volunteer year round. We're going to have over 120,000 volunteer hours from structured events like this in 2022. So, our associates, COVID had them on the sidelines for a couple years because of the mask mandates and weren't able to get out there and volunteer. So now they're hitting the ground running and making up for lost time. So we're glad to see it. So that's really it. Next slide. Really, once again, thanks for the opportunity just to give a few examples of what we have in place, and I look forward to the Q&A session.
Great, thank you so much, Lance, for highlighting Elevance's leadership in supporting community health and food as medicine programs. We would like to use the remaining time to engage in a Q&A session with our audience, so please continue to submit your questions in the Q&A tab, and I'll ask all of our panelists to come off of mute and you can all come back on video. So we've had a few questions come in around addressing inequities, and so I wanted to kind of put them out there for anyone on the panel to speak to. Really, what kind of research has been done to show that poor social determinants of health have a negative impact on food insecurity and poor health outcomes in a variety of communities around the country. So specifically asking about data related to urban rural communities or counties that have higher underserved populations. Where can one look for that data? And if anyone can just speak more to kind of addressing those inequities, particularly in urban and rural communities. And I will open this up to whoever would like to take it first.
Matt, do you want to talk about it in Ohio or?
Yeah, I can talk about it briefly in Ohio, but just a little bit, from a Feeding America perspective, there really is a very strong current development around how to deal with equity and across the country. I mean, food banking historically has been kind of an equality model. Everybody gets their fair share of what we have to spread out. And now we're recognizing that individual food banks are more resourced than others. So for us, I mean, we have a unique service area, 20 counties. I have 9 Appalachian counties. I have the 14th largest city in the country, one of the fastest growing counties in Ohio. So it's a unique mix of the country, but there's a real emphasis on equity. We're trying to explore what that means in a health equity world. How do we get fresh food? Because it boils down to, it costs a lot of money to move produce around the country. And if you're a small food bank in a rural area, that's really difficult. So we're trying to step into that space to say, how do we help each other? Years ago, we built mixing centers so small food banks could mix up a semi-load, not take an entire semi-load of one product, which they could not do. So we're learning more and more in that space, really trying to address it, from a, how do we take this product that's in various parts of the country and get it to where it is needed and match that up against the limited resources. So we're looking at it, if they're resource poor, how do we step in and help more than what they normally would have gotten in a fair share? To the data, I'd have to turn it over to you, Hilary.
Yeah, well, it's an excellent question. And as far as rural urban goes, there are many food insecure people in both rural and urban communities and suburban communities as well. And so one of the things that we try to hold in mind is that there are food insecure people in every county in America. Although people living in rural and in urban environments are both at higher risk of food insecurity compared to people living in suburban environments. The coping strategies for food insecurity can be a little bit different in those two communities. And one of the things that I think that helps us focus on is both that the challenges are different in urban and rural communities, but also that the opportunities for addressing food insecurity may be a little bit different in urban and rural communities. And when Matt talked about farming, for example, we're not going to farm ourselves out of the food insecurity problem in the United States. There's no way. And yet for an individual rural person, maybe this could be an important coping strategy.
Great, thank you.
I'm sorry that went out for a minute.
Oh, yeah, we could hear you. You're good.
You could hear me. Okay, great. And then in inequities in general, it sounds like you're getting a number of questions about equity and food insecurity in general. I elevated the racial inequities that we see in food insecurity. There are many other inequities. Households with children, particularly young children, are at higher risk of food insecurity. Households headed by a single parent are at much higher risk of food insecurity. And in particular, households with people who have a disability, which is really important when we're talking about food insecurity in the healthcare space. So we are working really diligently to try to create programs and systems and especially policies that will help, in particular, those populations at highest risk.
Excellent, thank you. One other question came in. Do we have any long-term information on individuals who've been prescribed healthy food? So looking at kind of the long-term impact of this approach, and if people, when perhaps they are then able to afford healthy food later, do they continue to maintain a healthy diet after they've transitioned?
The largest, I'm gonna take a stab at it first since it's a research question. The largest experiment we have is the SNAP program, the Supplemental Nutrition Assistance Program, formerly known as food stamps. It is very clear that SNAP is highly effective at reducing food insecurity rates, reduces food insecurity by about 20 to 30%, and by increasing people's food budgets, allows people to afford a healthier mix of foods. Very good data shows that when people enroll in the SNAP program, well, let's start with children. When children enroll in the SNAP program, they're less likely to become obese over time. They're more likely to graduate from high school. They're more likely to become economically self-sufficient, and they're less likely to develop diet-related chronic disease over subsequent decades of their life. This is really important and the strongest data we have. We also have data from the WIC program that shows that children who are exposed to these interventions to healthier foods do better, and their mothers do better when they are consuming those foods when they're pregnant. So that's our best data from the perspective of large national programs. Individual programs that are implemented on a local level are much more challenging to show impacts in terms of prevention of specific diseases like diabetes. These studies just aren't long enough, and they don't go they don't offer services for long enough. But the small studies that we do have are really promising that they have the capacity to have the same impact on health outcomes if we were able to sustain them for longer. One of the reasons to really think about bringing healthcare to the table in a very meaningful way is we need strategies to help support these types of interventions that will go on for a duration that would be sufficient to help prevent or manage a case of diabetes or a myocardial infarction or a case of congestive heart failure. These things add up really quickly in terms of healthcare costs.
One of the things I would add to that, to pick up on the SNAP thing, is several years ago we were lobbying on the Farm Bill, and we took healthcare executives and a doctor to lobby into Washington, and it was kind of first confusing to the senators and congressmen. Why are you bringing healthcare in here? I said, because we need to rethink SNAP from an entitlement we all love to hate to good public health policy. And we got our senator to actually use that on the ag floor, to really look at this differently, because the data is there that this will make a huge difference in this country.
Great, thank you. Another question came in. What is the most productive way for a food bank or food pantry to convince healthcare professionals to screen and intervene, to issue healthy food prescriptions, et cetera? Many healthcare professionals just don't seem to have enough time to add this to their normal practice areas. So how do we really encourage them to make that connection?
I'm going to be out of my element here a little bit, but I know there's some way of getting it into the charts, and Dr. Seligman can fill that in terms of whatever that IC charting that you do. But to really get food insecurity recognized, even my own doctor, they asked the question, when I go in, are you or anybody in your household food insecure? And I finally asked them, so what are you going to do with that? If I say yes or no. And that was really helping. One of the things we learned out of that diabetes research we did with Dr. Seligman was that doctors didn't screen. But once they did, they needed some place to refer people to. So there was a step in that, to do that. It's not easy. It's local. And I think, Feeding America's when we've been working on what's the national strategy. And the reality of it is, food, to me, healthcare is local, and how do you get doctors? We think by continuing to look at, their patients differently. I chaired a hospital board. At the very end of that was right when my term was when the ACA was coming into play, and they give me the entire checklist for where they don't want you back and making sure they're doing all the right things so they don't get you back. And I looked at all the doctors in the room and said, how was this plan going to work if you don't ask any questions about food? If you're not asking them whether they have it, I don't care what your income is, if you got your inability to prepare it, to acquire it, to bring all that in. This all predates the pandemic and all of us being able to online order. So there's better solutions today for a lot of people. But it's in that space that we've got to continue to build this connection, that healthy food matters. My counterpart in San Antonio said, who's going to pay for the food prescription? If your social determinant of health work and healthcare is simply making a referral, and you get paid for, the company that does the referral gets paid, but nobody helps pay the healthcare bill at the pantry level, at the food bank level, then there's a limit to what we can do with charity. But the food is there. We got to continue to build the connections to this. We've been able to show it works. We don't have long-term. patient, because we don't see people all the time. It's not like you're coming back to see your doctor, but it's in that space that I think you can build connectivity. We're going to partner when we open up a new market. We have 2 primary, 1 federally qualified health centers right next to the market so that we can build that connectivity. Ohio State's building another facility, and we're connecting food into that healthcare strategy.
And I'll add a couple of points from my perspective. Number one, you need a clinical champion. You absolutely need a clinical champion. It can be a physician. It does not have to be. And the second is that you need systems and structures and workflows set up within the clinical setting to make this work. If you just throw in another bunch of things for the providers to do, for physicians to screen for food insecurity, and then figure out how to connect patients to community resources, it's not going to work. But if you to make a system and a functional workflow, this is where we've seen this be really powerful. And the final thing I'll say is it does not have to be the physician who does the actual screening for food insecurity. And actually, best practices suggest that it probably shouldn't be. Patients report that they are much more comfortable disclosing and discussing food insecurity with people who aren't their physician, who might be the nurse or the nurse's assistant or the front desk staff. So what we generally say is a best practice is that physicians or other healthcare providers, in the case of it being a nurse practitioner or a physician's assistant, should follow up on every positive food insecurity screen, but they do not need to be the ones who are tasked with doing the screening themselves.
Great, thank you. We had a question come in around stigma. So how do we work to break the barriers to support health and reduce stigma in the areas of food insecurity and social determinants in general, really?
I could start, but try to keep it brief. To me, stigma and stopping judgment are 2 sides of the same coin, but and that we really need people to understand that there are people in this country that are struggling, big time, and it got exposed during the pandemic. And so, the idea of our market strategy is it looks like a grocery store. It feels like a grocery store. You're invited in, you get to shop. We tell you to come back. That's opposite of model that we use for decades in food banking and food pantries, where we give you a 3-day supply of food and hope we never see you again, kind of thing, as if that solved all your problems. But the idea is come. This is fresh food. Come get what you can use. Nobody's judging you. For all those, I remember 145,000 families that we've helped that have never asked for help before, that was really hard for them to cross the threshold of a free food distribution and get food. But recognizing that we're there, it's there, we have the food, we want you to come get it, and we're not judging. So if we could all just stop judging each other and just step up and help, I think we will reduce it.
I appreciate this question in particular because it gives us a chance to acknowledge the fact that we are coming to this as 3 people who, by our titles and by everything in the way we present, are clearly very privileged people. The best way to get rid of the stigma in this work is to stop being privileged people creating these solutions and to allow many, many more voices into the table to start creating solutions with us, or even be responsible for the solutions that they think work for their own communities. And that, I think, is where we are all headed. I wish we had some voices on this panel of people who were able to create or communicate those experiences from a more personal perspective. There are many, many policy solutions that we advocate for that have changed, been nuanced, and even been ditched, and we've started over because the way that we understand the policy solutions may be different from the people who are experiencing food insecurity, and we have to be able and willing to allow those voices to be heard if we're going to get rid of the stigma in these issues.
Thank you for that. I think we have time for one more question, and really, we have such a broad audience, and so I had some questions in around how people can best get involved. What are some of the ways to encourage an organization to get more involved, or the easiest way to get more involved yourself in terms of helping out in your community?
Yeah, so many ways. First off, I'm a firm believer in volunteerism. Get out there, get involved, get engaged, and when you volunteer, organizations find a way to get you even more involved. You know, volunteerism, serve on a committee, serve on a board, you know, do different things along those lines. I think the topic, when you look at it as a whole, can seem so big. And so all you can do is make a difference where you're at and create that ripple effect. So I start with volunteerism. I think that's a great place to begin. But then also look at your different networks and resources. What is my company doing? How are we engaged on the topic? Are there things that we can be doing from a philanthropic perspective or from a business perspective? But first and foremost, in my opinion, volunteer.
Great, oh, yes, go ahead. Oh, I think you're still on mute.
I really like that, and I think we all need to examine the places where we have power and use that power towards food security. And one of those places is by calling your own elected official and supporting good food security policies in your own community. Calls to our local elected officials can be extremely powerful. So vote, but also use the power of your email and your phone as well.
Great, thank you so much. Unfortunately, we are out of time. I would like to thank our excellent panel of speakers for being with us and our audience for joining us for this discussion. Your feedback is important, so please do take a moment to complete the brief survey that you will see on your screen. And also check out our website to see what other resources are available, including our recent infographic on hunger in America and the registration information for our next webinar, which will be on the relationship between health and incarceration. Thank you all for joining us today. We really appreciate it.